Se acerca el 36º Congreso Latinoamericano de Patología 2027, la fiesta científica más grande de nuestra especialidad. Fecha y lugar: Punta Cana, República Dominicana, el destino por excelencia en América Latina y el Caribe, con más de 48 kilómetros de arenas blancas que abrazan la mar turquesa, donde convergen descanso, bienestar, el ritmo de la vida moderna y la inigualable hospitalidad de los dominicanos. Punta Cana late en el corazón del Caribe como un destino de conexión global, con una infraestructura que supera los 127 hoteles y más de 80.000 habitaciones. Su aeropuerto internacional, el mejor conectado de toda la región, enlaza vuelos directos con más de 90 destinos internacionales, consolidando la zona como el auténtico punto crucial de encuentros internacionales de la región. Punta Cana se erige como el escenario tropical único, donde ciencia, cultura y magia convergen bajo un mismo cielo azul, con modernos centros de convenciones dotados de tecnología de última generación y un equipo humano de reconocida excelencia. ¿Y tú? ¿Ya estás listo para vivir la fiesta científica que une a toda la región? 36º Congreso Latinoamericano de Patología 2027, Punta Cana, República Dominicana. ¡Te esperamos! Se acerca.
Buenas tardes o buenas noches a todos. Bienvenidos a este curso de la Sociedad Latinoamericana de Patología, que hoy se engalana con grandes temas como son la biopsia de ganglio linfático y las biopsias de médula ósea. El doctor Sangüesa va a presentar a los profesores que hoy nos hacen favor de acompañar, que son grandes expertos en el área. Entonces, no falta en el día a día, en nuestras charolas, que nos llegue un ganglio linfático y una médula ósea. No vamos a ser expertos, pero cuando menos sabemos de inicio cómo podemos afrontarlas. Entonces, muchas gracias. Thank you very much, Dr. Belling, Dr. Schwarting, for being here with us. Martín.
Bueno, muy buenas noches a todos los colegas de Latinoamérica. Esta va a ser una clase en inglés. En la parte de abajo ustedes van a tener la traducción en español. Entonces, ustedes también pueden hacer las preguntas en español. Y pues empezamos con el doctor Eric Belling, que es hematopatólogo y director de hematología y citometría de flujo en Cooper University Hospital en Camden, Nueva Jersey. Él se formó en el Jefferson Medical College y realizó la subespecialidad de hematopatología en Thomas Jefferson University. Desde hace 20 años se ha dedicado al diagnóstico de las enfermedades hematológicas linfoides, con especial interés en los linfomas. Además de su trayectoria clínica y académica, es un educador altamente experimentado, ha participado activamente en la formación de estudiantes de medicina, residentes y becarios, impartiendo conferencias, liderando docentes y supervisando programas de entrenamiento en actividades de hematopatología. También se incluye como director del Fellowship de Hematopatología. Entonces, dear Eric, very welcome to our family. Hopefully, it's going to be your family in the next years. And very welcome for your conference. You can start whenever you want. You want. Please go ahead.
Okay. Well, thank you very much for that introduction. Tonight, we're going to talk about lymph node evaluation by core biopsy, or as I like to think about it, doing more with less. Fine needle aspirates and core biopsies are more convenient and quicker to obtain than excisional lymph node biopsies. Therefore, FNAs and core needle biopsies represent a major proportion of lymph node specimens submitted for diagnosis. In fact, at our institution and at many institutions, they are first-line tissue sampling techniques. Yet, general pathologists often feel less confident with core needle biopsies compared to excisional biopsies. To be sure, the inherent limitations of core needle biopsies their small size, their variable quality, fragmentation of the specimen, other artifacts, as well as the increasing complexity of lymphoma diagnosis and ancillary testing, result in substantial challenges to the pathologist. In general, in pathology, fine needle aspirates and core needle biopsies have been proven to be safe, economical, accurate, and rapid diagnostic techniques. The recipe for success in an FNA is good cellularity, a high quality preparation, as well as an experienced operator. Of course, we cannot overemphasize the importance of rapid on-site evaluation for assessing adequacy, triaging ancillary studies that we may want, as well as rendering preliminary diagnoses when possible. For core needle biopsies, the bigger, the more cores, the better. Touch preparations or smears from those core biopsies are always helpful. But what about FNAs and core needle biopsies for the diagnosis of lymphoma or lymph nodes specifically? FNAs and core needle biopsies in lymphadenopathy and lymphoma have been approached with much caution, and we have to ask ourselves why. I mean, there is certainly a high interest in this area, particularly with routine use of immunohistochemistry, flow cytometry, and other ancillary studies. And many papers have been published over the last 20 years. But what are the guidelines? What are the issues or challenges? And when is an excisional lymph node biopsy required? To be sure, the difficulty in lymphoma core biopsies and FNAs stem from the fact that Hodgkin lymphoma and non-Hodgkin lymphoma represent a diverse group of neoplasms with a wide range of histopathologic appearances. In addition, immunohistochemistry, flow cytometry, cytogenetics, and molecular studies are often necessary to improve the diagnostic accuracy. And while we may conclude that the accurate diagnosis of lymphoma in lymph node FNAs and core biopsies is possible given optimum specimens, awareness of pitfalls and mimics, and smart use of ancillary studies, it must be understood that excisional lymph node biopsies are always preferred. In fact, a early paper on the topic by Leung et al. Writes, while there is a definite role for FNA biopsy of lymph nodes, particularly in the discrimination of lymphoma from metastatic disease, malignant lymphoma diagnosis in a superficial lymph node is best followed up by an excisional biopsy, which allows complete histologic, immunophenotypic, and immunogenic workup. Our big societies kind of echo this thought. Let's see, very significantly according to the type of lymphoma. So diffuse large B-cell lymphoma has the highest core needle biopsy accuracy because the large monotonous cells are easily identified on limited tissue. Follicular lymphoma has a lower accuracy, only about 68% for all grades, and only about 8% for grade 3 because architectural assessment on core biopsy is limited. Classical Hodgkin lymphoma also has a lower sensitivity. Sometimes the Reed-Sternberg Hodgkin cells are sparse, few and far between. There's significant fibrosis, and you just can't appreciate the complex architecture. T-cell lymphomas have the highest non-diagnostic rate of 30%, and they are challenging even on excisional biopsies. How do we optimize core needle biopsy techniques? We can obtain multiple cores from different areas. We can get larger cores using larger needles, although this doesn't, the data on this is mixed. It may improve yield, but the quality of those cores, no fragmentation, shearing, or mechanical artifact or hemorrhage is actually more important. We also need to target the most PET-avid accessible lymph node whenever possible. and rapid on-site evaluation helps us triage materials for the ancillary studies that we might want. Very important overall is to have a systematic approach when evaluating lymph node core biopsies. This is kind of my system for evaluating core biopsies, and we can go through it step by step. So step one, we assess specimen adequacy, and as part of that, while we're doing that, we may want to look for clinical clues that raise suspicion for lymphoma. Step two, we can do a low power pattern recognition and try to see what we're thinking. We then, with all that information, we can try to form a kind of an overall impression whether we think we're dealing with a reactive or a neoplastic process. And there are a few principles that kind of help us with this. Next, we can go up to higher power and assess the cytomorphology. We can then integrate any immunophenotypic data that we may have. Maybe you have some preliminary flow cytometry data or a few initial immunohistochemical stains. You can integrate all that and then choose a comprehensive immunohistochemical panel. And then based on all of that, we can consider FISH or molecular studies to firm up our diagnosis. So let's go through it in more detail. So step one is assess specimen adequacy. It's an easy question. Is there viable and intact lymphoid tissue present? Yes or no? If no, rebiopsy. If yes, hopefully that lymphoid tissue is viable and not necrotic. A lot of times we can get necrosis in high-grade lymphomas, but the biopsy should include some viable tissue so that we can evaluate it properly. Fibrotic bands or other architectural features, like we might see in nodular sclerosis type of classical Hodgkin lymphoma, may not be seen in small biopsies. Tissue for flow cytometry is often helpful, but we have to remember that adequate viable tissue for H&E is our top priority. So if you have to choose only that you can only do one thing with the scant tissue that you have, it has to go for H&E. If the specimen is non-diagnostic, we can recommend rebiopsy. An excisional biopsy is often preferred, but if they want to try another core biopsy, I guess we could try that. So here are some clinical clues that might raise suspicion for lymphoma. If the lymphadenopathy is persistent, greater than 4 weeks without a cause. If the adenopathy is firm, rubbery, and painless, greater than 2 centimeters. If there are B symptoms, and by that I mean unexplained fevers, night sweats, or significant weight loss. Alcohol intolerance, which means pain in the involved lymph nodes after alcohol consumption, is often seen in classic Hodgkin lymphoma. Is there splenomegaly? How about effusion or ascites? Any cytopenias? And then an elevated serum LDH level. Okay, so some principles to get started. This will help us kind of differentiate between lymphoma and reactive processes. So when we're talking about smears and touch preparations in lymphoid hyperplasia, we generally see a mixture of small, medium, and large cells with occasional tingible body macrophages. In a core needle biopsy, we might see occasional primary and secondary follicles, and that might suggest to us preservation of the normal architecture. Atypical cells are always concerning, but we have to remember that they can have benign counterparts, like immunoblasts, for example. A diagnosis of non-Hodgkin lymphoma in FNA and core needle biopsy is largely based on the presence of a monotonous cell population or the disproportionate presence of one cell type. In classical Hodgkin lymphoma, the diagnosis depends on having the right atypical cells, those classic Hodgkin-Reed-Sternberg cells, in the right background, a mixed or polymorphous background. In any case, effacement of the normal lymph nodal architecture is a constant feature in almost all types of lymphoma. So that brings us to our low power pattern recognition. Here are some key morphologic patterns that we can identify on the core biopsy. Probably the easiest is a follicular pattern. The differential here might be between reactive follicular hyperplasia or follicular lymphoma, or maybe a few other things. A diffuse small cell pattern differential here might include chronic lymphocytic leukemia, small lymphocytic lymphoma, mantle cell lymphoma, marginal zone lymphoma, or lymphoplasmacytic lymphoma. A diffuse large cell pattern that we might see in diffuse large B cell lymphoma, anaplastic large cell lymphoma, primary mediastinal B cell lymphoma. And then sometimes they're in between. So a diffuse medium cell infiltrate with or without a starry sky pattern might suggest to you a diagnosis of Burkitt lymphoma or blastoid mantle cell lymphoma or even high-grade B cell lymphoma. A mixed cellularity or polymorphous pattern you might appreciate, and there you're going to think about classic Hodgkin lymphoma, peripheral T cell lymphoma, maybe even some reactive processes. A necrosis predominant pattern you might encounter in Kikuchi's disease, NKT cell lymphomas, or even an infarcted lymph node. In any case, the cytomorphology and the clinical features determine our choice of special studies. So if we're talking about a follicular pattern, on the left here, we have intact architecture with a proliferation of secondary lymphoid follicles of different size, and they have polarity, tingible body macrophages, and well-formed mantle zones. So we feel pretty good that that's reactive. On the right, we also have a proliferation of germinal centers, but here they kind of look monotonous. We don't see polarity. We don't really see tingible body macrophages, and we really see we really don't see mantle zones either, or if they are, they're attenuated. So if we talk about our diffuse patterns, this is pretty self-explanatory. There's really no architecture here, as you just have sheets of small lymphocytes on the left, large lymphocytes in the middle, and medium-sized lymphocytes with a beautiful starry sky pattern on the right. A polymorphous pattern, it is just as the name suggests, is a mixture of different types of cells, small lymphocytes, plasma cells, eosinophils, histiocytes. And then in this particular case, you also see a few large atypical Hodgkin-Reed-Sternberg cells because this is a case of Hodgkin lymphoma. In a necrotic background, in a necrotic pattern, you're just going to see necrosis and hopefully, if you're lucky, some viable tumor. And that might be the area that you're going to focus on for your special studies. Okay. So step 3, reactive versus neoplastic. So after looking at the low power pattern, maybe you've formulated an impression of whether you're dealing with a reactive or a neoplastic or an atypical process. So we already talked about looking at the cortex and looking at the follicles and whether there's a follicular hyperplasia with lymphoid follicles with polarity, tingible body macrophages, and well-formed mantle zones. But notice how the follicles here are spaced, whereas they're really back-to-back in the follicular lymphoma, and there's no polarity, and the mantle zones are just kind of altogether missing. Now, if we use an immunostain like BCL2, of course, we can differentiate between reactive and a follicular lymphoma quite easily because the neoplastic germinal centers will be BCL2 positive, but we'll get to that in a second. We also want to focus on the paracortex. Sometimes the paracortex can be expanded, and we could be looking at a paracortical hyperplasia. And the paracortex, when it's expanded, often contains a mixture of B and T cells with scattered immunoblasts and maybe foci of pigment, if you happen to be talking about dermatopathic change. But the architecture is still intact, and that may not be so easy to figure out on a core biopsy as much as an excisional biopsy. But with a little bit of effort, you might be able to have an opinion about that. In classic Hodgkin lymphoma, of course, the paracortex is also expanded, and we have this polymorphous background of cells. But of course, we have our characteristic classic Reed-Sternberg cells, which are highly atypical. And when we do immunohistochemistry, we'll have a classic immunophenotype that will lead us to correct diagnosis. So now we go to higher power. Higher power is something you want to do with caution, because when you go to higher power immediately, a lot of times you can scare yourself and you don't see the architecture because you're looking at it too close. But when we do go to higher power, the cytologic diagnosis of lymphoma is often based on a monotonous cell population, or it might be based on have highly atypical cells in an atypical background. But we have to remember the absence of normal architecture in a core biopsy or in an FNA is difficult to assess. And so we need to be careful. If we have presence of necrosis or abundant mitotic figures or apoptosis, that's concerning. And while sheets of large cells are often suggestive of high-grade lymphoma, we have to remember that infiltrates of small cells are not specific, but they're also not evidence of benignity either. Okay, so flow cytometry, if you're lucky enough to have it available early, can be very helpful. Flow cytometry is quick, and it's especially useful in low-grade non-Hodgkin lymphoma. It enhances the diagnostic rate when added to immunohistochemistry and core needle biopsies pretty significantly. And we really find it most valuable for discriminating reactive lymphadenopathy from B-cell lymphoma. It seems to be most successful there. It provides a detailed immunophenotype in one study, so that's great, but it does have limitations. You can't diagnose Hodgkin lymphoma. It often misses large cell lymphomas, both B and T. It gives no architectural information, and a fresh specimen is required at biopsy, of course. So that brings us to immunohistochemistry. Before we really dive in, some general principles for immunohistochemistry on core needle biopsy. I like to begin with a broad panel appropriate to the morphologic differential. I like to avoid unnecessary antibodies whenever possible. And by all means, check the history and any preliminary flow cytometry data to help guide you so you don't waste tissue. Consider cutting unstained slides if the tissue is scant and additional studies are anticipated. Add additional antigens and additional ancillary studies in subsequent panels based on the initial results. So here is my suggested initial panel for small cell infiltrates, follicular infiltrates, and reactive appearing lymph nodes. So here you can see my panel of immunomarkers. And this panel is going to highlight architecture. That is, it's going to show us the B cell zones and the T cell zones, whether there's compartmentation between the two, and whether there are follicles present. It includes 2 B cell markers for some redundancy. It includes 3 T cell markers. It includes CD10 and CD5, which are key markers for B cell lymphoma subtyping. It includes some markers for follicular dendritic meshworks. It includes markers CD10 and BCL6, which highlight the germinal centers. It includes BCL2, so we can determine whether those germinal centers are reactive, negative, or neoplastic, positive. And BCL1 and SOX11 for mantle cell lymphoma. CD43 is an interesting marker. It marks T cells, but it's often aberrantly expressed in B cell lymphomas, so it can be useful in showing you that something atypical is going on. Ki67, in addition to showing you the proliferative rate, I also find very helpful in highlighting architecture. You might pick up where the action is, I guess. Consider CD30 if large and or bizarre cells are present, and consider a pan-CK immunostain if carcinoma is suspected or at all possible. So here we see my panel at work on an atypical lymphoid infiltrate, and we can see right away that atypical lymphoid infiltrate is nodular. It has nodules of B cells. And further, we can say that there is some compartmentation of the B cell and T cell zones. The T cells are in between these nodules of B cells. And the nodules of B cells actually are follicles because they correspond to CD21 positive follicular dendritic meshworks. We can do even better than that because those follicles are actually secondary lymphoid follicles because BCL6 highlights the germinal centers that they contain. And finally, those germinal centers are BCL2 positive, so we can conclude that they're neoplastic germinal centers, and this is a case of follicular lymphoma. See how easy it is? Now, don't be scared because in the next image, you're going to see an algorithm that the NCCN puts out for small B cell lymphomas, and this looked absolutely terrifying. But I think my algorithm is a little bit easier to follow. If you have a diffuse small B cell infiltrate that's 5 and 23 positive, you have CLL SLL. If you have a diffuse B cell infiltrate that expresses cyclin D1 and SOX11, then you have a mantle cell lymphoma. If you have a follicular B cell infiltrate that expresses BCL2, then you have follicular lymphoma. If you happen to have a diffuse B cell infiltrate that it co-expresses CD103, 25, and 11C, and those markers we often do by flow cytometry, you have hairy cell leukemia. And if you have a diffuse small B cell infiltrate that has a non-specific immunophenotype, you may be looking at marginal zone lymphoma or lymphoplasmacytic lymphoma, which we can distinguish with mutational analysis or MYD88 or CXCR4 kind of in some later studies. Okay. So
Eric,
you have a large...
Just hold 1 second because the slides are not moving forward. Can you check in your presentation? Because it's frozen in the step 3.
It's frozen in step 3?
Yeah.
Okay. So let's go, let me X out and go back. And how about now? Can you see step 4?
No.
No. Okay. All right.
It's frozen. Maybe you can...
Maybe it stops sharing and share again. What do you think?
Yeah, that I think
Maybe.
that will be the best way.
Okay. We'll try that. Window, share. How about now? Do you see, is it different? You see 4?
It is still don't appear in your screen.
Okay. All right. Let's try it again here. Okay. Let's see. Stop sharing. Let's see. All right. Share again. Let's try the entire screen this time and then go back. Window, share. Any luck? Still frozen?
Well,
Still frozen.
we can see your screen.
Okay. Let's see. Stop sharing. So you can see me or you can see the PowerPoint?
No.
Okay.
Neither you, neither your presentation.
Okay.
I can put the presentation on.
Hold on. Let's see. I'll put the video back on. Let's see. Strange. All right, let's share again. Should I try logging out and logging in again, do you think?
Oh, maybe.
Maybe that will be
Okay, I can do that. I mean, it should be quick because it comes up pretty quick. So let me log out of Zoom and log back in again, and then we'll see what happens.
That's perfect.
Okay, let's try that. All right, here we go. Leave. I'll try leave. Leave.
Bueno, vamos a ver de qué solucionar. Qué raro, ¿no?
Sí. No sé si porque la plática será muy pesada con imágenes, pero eso no tiene que ver, ¿no?
O tal vez la transmisión, la traducción. Puede ser que algo
Puede ser.
ha modificado. Jason, ¿estás por ahí? Oh. Okay, Dr. Eric is back. You are mute, Eric.
Eric, we cannot hear you.
Okay, can you hear me now?
Yes.
Okay, all right,
Yes.
We
good,
can
good,
see
good.
you perfectly.
Okay, good. All right, so now I'm going to share again, and we're going to, here we go. Hopefully, okay, are we back?
Okay,
Yes.
you're back.
There you
Yeah,
are,
back?
step 4. Yeah.
there we
Okay,
go.
so
That's
should
We
we
are
start?
back and it says step 4. I
Step
think
four,
that's where you
okay.
wanted to be.
Yeah, I think that's where we wanted to be. So, okay, so step 4, assess cytomorphology. Cytologic diagnosis of lymphoma is often based on a monotonous cell population or highly atypical cells and a highly atypical background. Have to remember the absence of normal architecture is difficult to assess in small specimens. And I'm just going to get rid of a little window here. The presence of necrosis or abundant mitosis, apoptosis is concerning. And while sheets of large cells are certainly suggestive of a high-grade lymphoma, infiltrates of small cells are nonspecific. They don't give you, they don't really tell you that you're dealing with a low-grade lymphoma, but they're not evidence of benignity either. Okay, so flow cytometry is something that we do pretty early in the process. If you're lucky to have flow cytometry available early, it's quick and often helpful. It's especially good in low-grade non-Hodgkin lymphomas. It enhances the diagnostic rate when added to immunohistochemistry and corneal biopsies pretty significantly. And it's most valuable for discriminating reactive lymphadenopathy from B-cell lymphomas. It's pretty good at doing that. It gives you a detailed immunophenotype in one study, but it does have significant limitations. You can't diagnose Hodgkin lymphoma. You often miss large cell lymphomas. It gives no architectural information, and fresh specimen is required at diagnosis. Which brings us to immunohistochemistry. So when I'm doing immunohistochemistry, I like to begin with a broad panel appropriate to the morphologic differential and avoid unnecessary antibodies when possible. Check the history and any preliminary flow cytometry data that you might have. Consider cutting unstained slides if the tissue is scant and additional studies are anticipated. And add additional antigens and ancillary studies in subsequent panels based on the initial results. So here is my suggested initial immunohistochemical panel for small cell infiltrates, follicular infiltrates, and reactive appearing lymph nodes. So here you can see all the markers that I advocate doing all at once on those types of infiltrates. And the reason you want to do that is it's going to highlight the architecture for you. It's going to show you the B cell zones and the T cell zones, whether there's compartmentation between the two, whether there are lymphoid follicles. It has some built-in redundancy. It has 2 B cell markers. It has 3 T cell markers. It has CD10 and CD5, which are key markers for B-cell lymphoma subtyping. It has a few markers for follicular dendritic meshwork, so we can verify that we do, in fact, have follicles. It has some markers for germinal centers, CD10 and BCL6. It has BCL2 in it, which is going to differentiate between reactive germinal centers and most neoplastic germinal centers. It's got some markers for mantle cell lymphoma, BCL1 and SOX11. And it's got CD43, which is going to do 2 things for us. It's going to be a T cell marker, but it's also going to be often present in some B cell lymphomas being aberrantly expressed there. Ki67 is something I always do. It gives you a proliferation rate, makes you, gives you some information whether you're dealing with maybe a high grade or a low grade process, but it also kind of clarifies the architecture for you. It shows you maybe where some of those secondary follicles are, and it also kind of shows you the architecture. Consider doing CD30 if large and or bizarre cells are present, and consider a pan-CK if carcinoma is suspected or possible. Okay, don't be scared, but this is a very complex algorithm that the NCCN has put out on small B-cell lymphomas. And it looks, honestly, it looks so confusing. I don't even want to look at it anymore. I think my algorithms are a little bit easier to follow. If you have a small B-cell infiltrate, that's diffuse and it's 5 and 23 co-expressing, you probably have chronic lymphocytic leukemia or small lymphocytic lymphoma. If you have a diffuse B-cell infiltrate that expresses cyclin D1 and SOX11, then you probably have a mantle cell lymphoma. If you have a follicular B-cell infiltrate that is BCL2 positive, then you have follicular lymphoma. If you have the markers 103, 25, and 11C expressed on your B-cell infiltrate, which we often do by flow cytometry, you have hairy cell leukemia. And if you have a non-specific diffuse B-cell infiltrate, why then your differential would include mantle zone lymphoma, marginal zone lymphoma versus lymphoplasmacytic lymphoma, which we can distinguish by MYD88 and CXCR4 mutational testing. So my panel for large cell infiltrates is a little bit different. It's also going to highlight the architecture for us, and it's going to show us the growth pattern, diffuse or nodular. It's going to have 2 B-cell markers, 2 T-cell markers. It's going to have several markers that help us with B-cell lymphoma subtyping, specifically whether it has a germinal center B-cell phenotype or a non-germinal center phenotype according to the Hans algorithm. It's going to have those follicular dendritic markers. It's going to have BCL2, which is going to be negative in reactive germinal centers and Burkitt lymphoma. And it's going to be positive in neoplastic germinal centers. Our markers for mantle cell lymphoma are proliferative marker Ki67. And I also do EBER because EBER is required for large B-cell lymphoma classification, so I always do that. And CD30 is always a good marker to do in any large cell infiltrate. Strong and diffuse positivity on non-B cells is kind of what you see in anaplastic large cell lymphoma. And sometimes CD30 is a target that on B-cell lymphomas that the clinicians may wish to know. For large B-cell lymphomas, FISH for MYC, BCL2, and BCL6 is mandatory to identify Burkitt and double and triple hit lymphomas. So here is the NCCN algorithm for large B-cell lymphomas. And again, it looks very complicated, but I kind of advocate doing all those markers at once and taking a look at the results and kind of putting it all together that way. So here you have a large cell infiltrate, which is CD20 positive. So it's a large B cell infiltrate. It's negative for CD5. So CD3 looked the same, which I didn't show. It's positive for BCL6. It's positive for MUM1. So it has a CD10 was negative, which I didn't show. So it has a non-germinal center immunophenotype, but it is EBER positive. So it becomes an EBV positive large B-cell lymphoma, and the Ki67 rate reassures us that it's very high so that we have the right diagnosis. So, okay. So for immunohistochemistry for Hodgkin lymphoma, we always kind of have trouble determining what cells are expressing what marker. We always want to make sure that we have scattered a classic Hodgkin-Reed-Sternberg cell cells present in a polymorphous background to start with. And there may or may not be sclerosis. We have to start with the right cells in the right background. If we have the right cells in the right background and we do the immunohistochemical stains, Hodgkin-Reed-Sternberg cells have a characteristic immunophenotype. They are CD30 positive, are often CD15 positive, are weakly PAX5 positive and MUM1 positive, negative for CD45, CD3. They can be positive for CD20 and EBER, and if the cells are positive for CD20, we usually have to do a few other immunohistochemical markers like OCT2 and BOB1 and CD79A, which should be positive in classic Hodgkin lymphoma. Now, the background in classic Hodgkin lymphoma will be predominantly small T cells, and it's important, since we're dealing with small biopsies and a core biopsy, not to overreach. If everything is not perfect, get an excisional biopsy. We have to have the right cells in the right background. And we have to remember that Hodgkin-Reed-Sternberg-like cells are not always specific and can be seen in other entities. Nodular lymphocyte predominant Hodgkin lymphoma has a different immunophenotype. It is CD20 and CD45 and CD79A positive, PAX5 strongly positive. It's negative for CD30 and always negative for EBER. And the difference in the background is that there are many small B cells in the background, often in nodules themselves, and there are expanded CD21 positive follicular dendritic meshworks. Of note, flow cytometry and molecular studies are not helpful in Hodgkin lymphoma. So my recommended immunohistochemical panel for suspected T-cell lymphomas you see below. Obviously, they include a lot of T-cell markers, but to start with, it's important to understand that diagnosing T-cell lymphoma, especially in a core biopsy, is extremely difficult. Architecture is often uninterpretable. What we want to look for, which is very helpful, is loss of expected pan-T cell markers. And if we think it has a T follicular helper origin, we have to do all the T follicular helper markers. We need 2 to 3 that are positive, and CD10, BCL6, PD1, CXCL13, and ICOS are the ones that you want to do. By flow, an aberrant CD3 dim, CD4 positive T cell population is seen, and that's very helpful in leading you to the correct diagnosis. Also in T cell lymphomas, EBER-ish is essential for proper classification. Molecular studies for TCR beta and gamma are useful, but not sufficient alone for the diagnosis. And often we wind up doing additional markers like cytotoxic granule protein markers, TIA1, granzyme B, and perforin to kind of refine our diagnosis. So here we have a core biopsy with an atypical, a diffuse atypical lymphoid infiltrate. And we see right away this infiltrate is negative for CD20, so it's not a B cell infiltrate. In fact, it's a T cell infiltrate with CD3 positivity throughout, but CD5 is completely negative. So aberrant loss of an expected antigen is as significant as aberrant antigen expression. So the loss of CD5 kind of indicates to us that this population is probably neoplastic. And in addition, we see that CD30 is strongly and diffusely positive, and Ki67 is very high. So this is a case of anaplastic large cell lymphoma, a T cell derived neoplasm, of course. Okay, so here's the NCCN pathway for T cell lymphomas, and it is also very confusing. You can read that if you want to. I'm not sure I would. Okay, so that is the immunohistochemical approach. We want to finish off with some ancillary studies. MYC, as we mentioned, MYC, BCL2, and BCL6 rearrangements are essential to classify high-grade B-cell lymphomas. We may wish to do FISH for T1114 or T1418 to confirm mantle or follicular lymphoma. In molecular pathology, IgH and IgK gene rearrangements are good for confirming B-cell clonality. TCR gene rearrangements great for T-cell clonality if it works. If it's positive, and MYD88 and CXCR4 mutation analysis to help differentiate between marginal zone versus lymphoplasmacytic lymphoma. Okay, so we've done all the hard work, but it's important to understand that there are very significant pitfalls when dealing with small biopsies, and it's important to know when to recommend excisional biopsies. So pitfall number 1, follicular lymphoma grading. Architecture is limited on core biopsy, and grading is unreliable. There's also a lot of sampling artifact. If you suspect high-grade follicular lymphoma, you need to recommend excisional biopsy for definitive grading. Pitfall number 2, classic Hodgkin lymphoma. A lot of times, Hodgkin-Reed-Sternberg cells are rare. There's a lot of fibrosis, and there are Hodgkin-Reed-Sternberg-like cells in non-Hodgkin lymphoma conditions, and this makes biopsies, core biopsies, very challenging. Additionally, mediastinal gray zone lymphomas and composite tumors like classic Hodgkin lymphoma mixed with primary mediastinal B-cell lymphoma may not be identifiable in small biopsies. and flow cytometry and molecular studies are not helpful. Nodular lymphocyte predominant Hodgkin lymphoma is very difficult to diagnose on core needle biopsy, and that's because of the architectural complexity. The relationship between the LP cells, the small B cell nodules, and the follicular dendritic cell meshworks might be difficult to figure out. The major challenge in core needle biopsy is to differentiate nodular lymphocyte predominant Hodgkin lymphoma from T-cell histiocyte-rich large B-cell lymphoma because both tumor cell populations have the same immunophenotype. Nodular lymphocyte predominant Hodgkin lymphoma also overlaps with progressively transformed germinal centers as well as lymphocyte-rich classical Hodgkin lymphoma, and again, flow is not helpful. More pitfalls, just two more. T-cell lymphoma, as we mentioned, is very difficult at best to diagnose and has a 30% non-diagnostic rate. There's a lot of morphologic overlap with reactive conditions. The neoplastic T cells can often be bland, and they can be mixed with B cells, plasma cells, eosinophils, immunoblasts, and expanded follicular dendritic meshworks, which is a key diagnostic feature of some T-cell lymphomas, may not be evident. Flow also misses a lot of T-cell lymphomas. The final pitfall is abundant necrosis. Many lymphomas can show geographic necrosis, and immunohistochemistry on necrotic tumor should be avoided. You might want to ask if there's any history of recent steroids or chemotherapy. That might be the cause. So in the end, there's a lot of studies that highlight the need of ancillary testing and working with core needle biopsies. If we're going to be asked to do more with less, then we need to do more testing to confirm our morphologic impression. When do we need to recommend excisional biopsies? Well, when you have a non-diagnostic or equivocal core needle biopsy result, when we have a suspected Hodgkin lymphoma, especially if the initial core needle biopsy is inconclusive, if we suspect T-cell lymphoma, if we ever need if we ever need to grade follicular lymphoma, like if we thinking a grade 3 versus a grade 1 to 2, we probably should get an excisional biopsy. And whenever there's significant discordance between imaging findings and the histopathologic diagnosis under consideration, an excisional biopsy is probably a good idea. So what we want to do to kind of show the workflow of a lymph node core biopsy is we want to assess adequacy, and if inadequate, recommend rebiopsy. Look at it. If it is adequate, look at low power patterns, generate a morphologic differential, maybe come up with an impression, benign or reactive or atypical. Look at high power, assess the cytomorphology. Initial immunohistochemical panels should be informed by flow. And we have to kind of weigh our best guess versus the tissue that we have to work with. Immunohistochemistry and steps with unstained slides should be considered if tissue is real scarce. Additional immunohistochemistry based on the initial results, molecular and FISH as needed. And we need to integrate the history and the clinical and imaging data. And finally, when possible, synthesize as specific a diagnosis as possible. And if it's non-diagnostic or equivocal, recommend excisional biopsy. So what are the take-home messages? Core needle biopsies provide lymphoma diagnoses in about 90% of cases in experienced hands, but remain less conclusive than excisional biopsies. Diffuse large B-cell lymphoma is the most reliably diagnosed lymphoma on core needle biopsy, while T-cell lymphoma and Hodgkin lymphoma remain the most challenging. A systematic immunohistochemical approach informed by morphology, flow cytometry, and the clinical picture is essential. Use of ancillary studies, FISH and molecular can help us maximize our diagnostic yield, and to recognize that even in experienced hands, difficult and equivocal cases often require additional tissue sampling and excisional biopsies for definitive diagnosis. And so with that, I thank you. And those are the references. Thank you very much.
Thank you very much, Eric. First of all, our deepest apologies for all the problems that we experienced during the broadcast. It's the first time that it happened in 3 years that we are doing this course. We thank you for the bottom of our hearts, this superb lecture, because it's very practical. So if you have any question or comment, dear Isabel, please go ahead.
Yes. Well, first of all, thank you very much, Dr. Belling, for this wonderful lecture.
Thank you.
You cover everything, but besides, still, I'm not a hematopathologist, but I, from time to time, get some lymph node biopsies. So when we we are not an expert in hematopathology, can realize when there is any sampling errors. For example, some lymph node may have a focal or heterogeneous involvement by a lesion. So how can we easily realize about that it is not benign, but it's maybe a focal involvement or heterogeneous involvement of the lymph nodes?
Yeah, I mean, I think one thing is if the clinician is telling you, well, this lymph node is really big, or it's growing rapidly, or there's something wrong with it, and you get what they give you just doesn't make sense. It looks completely benign and quiescent. Right there, you kind of know, well, this probably isn't. It's not corresponding to what clinicians tell you. So if it's possible, an excisional biopsy, if the clinician is not happy, an excisional biopsy is recommended. Otherwise, in terms of, some partial involvement does happen. And again, you're looking for the disruption of the architecture. So if you're a breast pathologist, I think they told me that you see a lot of breast. So, you might get a lot of axillary core needle biopsies, as we do, looking for sentinel nodes. And I can't tell you how many times, okay, there's no carcinoma, but hey, wait a second, I don't see any follicles at all, and it looks monotonous, and there's something going on, and it turns out to be a CLL or something. And then maybe if you ask the right questions, you'll find out that the patient also has a history of CLL that they didn't tell you, or something like that. Or maybe it's a new diagnosis. But, what you want to look for is, you always want, a lymph node that they're biopsying. They're probably biopsying it because it's enlarged. So if it's enlarged, you kind of expect that you're going to find at least one or two follicles. So if I don't see any follicles, primary or secondary, that already gets me very concerned. And if I see an infiltrate that I don't recognize, or I'm not sure, I mean, I think throwing an immunohistochemical panel on it, even maybe just a CD3 and CD20 to highlight the architecture, maybe a CD21. If you think there are germinal centers there, you may want to do a couple germinal center markers too. And a Ki-67 is always a good idea, because at least that'll tell you, okay, how proliferative are these cells that I'm looking at. If you have a small cell infiltrate and the Ki-67 rate's 100%, which we've seen, that will certainly shock you, and it may lead you to do more things. So, you could do a limited panel, and then if you're reassured, just kind of drop it at that and call it reactive. But if you see anything that bothers you, you do the whole panel that I mentioned.
Thank you. And my second question is more or less related to the first one, but it happened to me once. How can we approach a case when the morphological, immunohistochemistry, and clinical findings are not entirely concordant?
Yeah. Okay. So the morphology is different than the clinical, which is different than the okay. Well, I mean, I think in a case like that, if the clinician's worried about it and they're telling you, well, we're really worried about this, and you get something that just doesn't jibe. I mean, I think if recommending an excisional biopsy is never a bad idea, but if it, you can only diagnose what you have with a tissue that they gave you. So, definitely, you would probably do the immunohistochemical panel. Maybe you have flow, maybe you don't, but the immunohistochemical panel, you look for the architecture. And if you come to the conclusion that it's atypical and you can't say what it is, that gives them a green light to get more tissue. But if what you have is reactive and they're telling you there's no way this is reactive. I mean, you can put a comment in and say something like, I don't have any definite evidence of a lymphoproliferative disorder or other reason to explain the lymphadenopathy or the findings the patient has. But if lymphadenopathy persists or suspicion for lymphoma is very high, then you recommend excisional biopsy. That's kind of what I do quite frequently in small biopsies. And, again, I mean, that watch the patient and maybe they didn't biopsy the right node. I mean, sometimes the patient's supposed to have a really large or PET positive node. And it turns out that when they went and biopsied it, they biopsied a different node that's not involved, so that might also be what's going on. So that correlation is really important.
Thank you very much.
So you can only diagnose what's on the slide. So no matter what anyone tells you, you have to go with the facts. But if there are danger signs, if there are like alarm bells going off around you clinically, then it's possible that it just wasn't sampled correctly.
Exactly. Thank you so much, Dr.
Yep.
Eric.
Okay. Thank you very much, Eric. In order to keep on time the session, we are going to move forward our next profesor, that is Roland Schwarting, que es un profesor y presidente del Departamento de Patología y Medicina del Laboratorio de Cooper University. Además es profesor de la Universidad de Rowan y profesor adjunto del MD Anderson. Es un destacado profesor con mucho recorrido. Ha trabajado en el Sloan Kettering Center de Nueva York y donde realizó muchas contribuciones científicas importantes como el descubrimiento del anticuerpo monoclonal BREP4 y ampliamente utilizado en la patología, en la patología. También pues ha visto muchos estudios. Es un profesor internacional con muchos estudiantes. Fue director del programa de fellowship en hematopatología y ha mantenido una extensa actividad a lo largo de la carrera en Estados Unidos como en Europa. It's a big honor to have you, Dr. Schwarting. Please go ahead with your lecture. And one more time, sorry for the inconvenience that we are having, but hopefully everything is going to be all right now. Please go ahead with your lecture.
We will see about this. Can you hear me at least?
Yes.
Okay, so while your introduction of me was in Spanish, I recognized a few things. So I think it was very, very kind. So thank you very much. Thank you very much to Dr. Alvarado and to Dr. Sangüesa, who are the moderators tonight. Thank you very much for the invitation. So I'm greeting our friends and colleagues in Latin America. So
welcome to our family.
Yes, no, that's very nice. Now the adventure begins. Let me try to share and then we will see what's happening. Okay. Can you see this?
Yes.
Okay, now let me switch to slideshow. Can you see this?
Yes.
Yes.
You are okay now.
So I know it is very late. I know that a lot of us are very tired. So my presentation, in order to take this into account, will be very simple. Instead of just saying diagnosis of bone marrow biopsies, I could also say principles of bone marrow biopsies. If you listen very carefully, then you can make a lot of diagnosis even if you know almost nothing. Doesn't that sound promising?
We hope so.
Okay. Okay, so before I start, let me just give you two book recommendations. Of course, we all know the Blue Bible, because the field of hematopathology has expanded so much. Now we have 2 blue Bibles for WHO5, which doesn't make life necessarily more simple. Then I also highly recommend the bone marrow atlas from Foucault and colleagues. So if you are interested in cytogenetic changes, there's nothing better, and it's free, and you can just search for it on the internet. That's the Atlas of Genetics and Cytogenetics in Oncology and Hematopathology. Just search for this, and then you can find just about any chromosomal abnormality that was ever discussed, discovered related to any particular hematologic malignancies. So these sources I highly recommend. I've used pictures from these sources without indicating this in detail. So what do we need if we want to do bone marrow diagnostics? On the morphology side, we need a good core biopsy. Then, if you have a core biopsy, you can prepare touch preparations, in particular if you don't have so great aspirate smears. It could be helpful if you have an aspirate clot section that also contains bone marrow elements, because you can do studies on this clot section that you cannot do in decalcified material. Very important to identify cells morphologically in the right Giemsa stain are good aspirate smears. And what's also important, your bone marrow findings always have to be compared with findings in peripheral blood smears, or as we say in CBCs, or complete blood counts. That's very important to compare the findings in peripheral blood with those in the bone marrow biopsy. Then, of course, we have a number of ancillary technologies which we almost always apply in bone marrow diagnostics. That is flow cytometry, essentially since the end of the 1970s. Then immunohistochemistry. And I was fortunate enough to contribute to a number of important tissue markers that you are using in your current practice. For example, CD30, which is BERH2, or BERF4, or the second marker against CD103, markers that are used by flow cytometry, CD22 and CD11C in the diagnosis originally in hairy cell leukemia, were markers that I produced. So protein electrophoresis is very helpful in patients, for example, who have monoclonal gammopathy or plasma cell myeloma. Then we used in every single bone marrow case still conventional cytogenetics and FISH studies. A few years ago, people believed conventional cytogenetics was dead. The opposite is true. We use it more than ever. Then we conduct, of course, some basic molecular studies like gene arrangement studies for T cell receptor and immunoglobulin heavy chain and kappa light chain, etc. Now, for all leukemias that come into our house, we do in-house next generation sequencing. You have to do it for a number of reasons. I will explain this later in a little bit more detail. It is of diagnostic significance. Certain leukemias have certain mutations, and they are characterized by those nuclear sequence changes. And also, you identify targets for new and established drugs against hematopoietic malignancies. So what else is needed? Just a slight variation of what I've said before. Clinical information is important. I don't know how your clinical colleagues in South America do it. Ours very often fail. They don't tell us very important details from a patient's previous diagnosis. So we have to know if somebody has a previous diagnosis of a certain type of lymphoma, etc. So tell your clinicians, please give us clinical information. So we need a good and generous decalcified biopsy, which should not be fragmented if at all possible. So we need, of course, smears that contain particles. Particles means there's cells in these particles that enter suspension, and we can evaluate these cells on these bone marrow smears. Bone marrow smears should be performed immediately at the bedside, and they should be stained with white Giemsa. Then we have, of course, a number of special stains, such as iron stains and reticulin stains, and then, of course, a large number of immunohistochemical stains if needed. So here you see on the right upper side, there's a nice cylinder. This is a nice bone marrow biopsy, and you can use this bone marrow biopsy in order to generate touch preparations, which are seen here in the left lower corner. So that is already a very important specimen, and equally as important is the bone marrow aspirate that you use to disperse the cells on a glass slide and stain them with white Giemsa. You cannot identify or characterize cells in a bone marrow biopsy. You can only do this in the bone marrow aspirate smear. So, for example, if you want to identify dysplastic changes in a bone marrow, you need to have a good aspirate smear. You cannot do it in the bone marrow biopsy. So the smears should be thin. This looks really ideal. You can nicely identify maturing myeloid cells here, from promyelocytes to band forms, segmented neutrophils, some lymphocytes, etc., etc. This is how it should look. If a smear is not produced immediately, then it starts to clot. And then you have clumped cells. If you have a background of clumped red cells, your white cells that you would like to identify look different. They shrink, they look small. You cannot identify them anymore. So you have to tell your clinicians, please give us good aspirate smears. And don't believe that we always get good aspirate smears. So our diagnosis is based upon comparing normal versus abnormal. That sounds very trivial. Let's start with something very trivial. The first thing that comes to mind when you look at a bone marrow, excuse me, is cellularity. So that sounds so easy. What is normal cellularity? So there are two variables. Number one, it depends on where you take your bone marrow aspirate smear from. And number two, age. So here is the typical distribution of hematopoietic elements in a 50-year-old. And when you take a bone marrow aspirate from the iliac crest here, then it's approximately around 50%. Now let me compare this with people of other ages. On the left side, you see a 5-year-old. In a 5-year-old, the entire skeleton is hematopoietic. So you would expect a different cellularity. In the middle, we have again our 50-year-old adult, and on the right side, a 70-year-old. So where you have less cellularity. And again, what is yellow here is fat marrow, so non-hematopoietic marrow. And what is red is hematopoietic marrow. Now, this is the bone marrow from an iliac crest biopsy in a 50-year-old. And the rule of thumb is that cellularity from the iliac crest equals 100% minus age. So what does that mean? If somebody is 50, then 50% is normal. If somebody is 70 years old, 30% is normal. So again, what you have to know is the anatomic site from which your biopsy comes from, and secondly, the age. That you have to know in order to determine what is normal. This is probably the first impression we get when we look at somebody's bone marrow. What is the cellularity? So an important ancillary technology is flow cytometry. And I want to show you here how the cells in a normal bone marrow look if identified by flow cytometry. So we always start with a graph that depicts CD45, which is leukocyte common antigen, versus site scatter. So what is site scatter? When the laser beam hits the cells, then there is scattered light all around the cells. So site scatter means it's 90 degrees oriented towards the laser beam. It's a measure of internal granularity. CD45, of course, is leukocyte common antigen, and it's expressed to a variable degree in all white blood cells. So here, for example, we have a fairly well-defined population with relatively large CD45 expression. These are our lymphocytes. Then we have a group of cells here which contain myelocytes in blue here, more mature granulocytes, and promyelocytes here in orange. In between is the monocyte population. And here we have a relatively small population in a normal bone marrow, which represent blasts, myeloblasts, and also lymphoblasts, mainly B lymphoblasts. We call these blasts also hematogones. And then we have a population here which has less CD45 expression, which represents plasma cells. So the marvelous thing about flow cytometry is that, and this is the expression that's used, we can gate on these cell population. We can tell the machine, tell me only the expression of these lymphocytes. Tell me only the expression of these myeloblasts/lymphoblasts. So this is called gating. So if we have an abnormal cell population, which is not the case in this graph, we can specifically and individually identify the immunophenotype of that abnormal cell population. So this is the beauty of flow cytometry. So here we have an example of hypercellular bone marrow in a 50-year-old. And you can easily see this is hypercellular because it's not 50% cellular, maybe it's 90 or close to 100% cellular. So it takes one quick glance and you identify this bone marrow as abnormal. It's hypercellular, and in this case, it's a patient with chronic myeloid leukemia. So hypercellular bone marrow can mean many different things. So in this case, the patient with CML on the left side, you see many abnormal megakaryocytes, small and hypolobated, as we say, for this specific disease. So that is an example for effective hematopoiesis, because normally patients with CML have a high white blood cell count. This patient had a white blood cell count of 150,000. On the other side, this is an example on the right side of ineffective hematopoiesis. It looks actually pretty similar to the image on the left side. But in this case, and this is why a complete blood cell count peripheral blood findings are so important. This patient had a white cell count of 2,000 and essentially pancytopenia. So even if there's some resemblance in the appearance of the bone marrow, the underlying process is entirely different. So let's start with an example of myelodysplasia. Myelodysplasia being ineffective hematopoiesis. So what is a myelodysplastic syndrome, MDS? It is a stem cell defect where the hematopoietic cells look very abnormal It could be in one lineage, in two lineages, or three lineages, meaning in the myeloid lineage, in the erythropoietic lineage, or the megakaryocytic lineage, or in all three of them. And again, in almost all instances, it's an example for ineffective hematopoiesis. Yes, there are also types of MDS where you have low cellularity, like 10%, for example. But in most cases of MDS, we are dealing with ineffective hematopoiesis. Lots of cells in the bone marrow, but very, very few cells in the peripheral blood. So here is how it could look. Let's go to the right corner here. This is the morphology of a normal megakaryocyte. Why is this normal? Because a normal megakaryocyte contains a nuclear convolute, which can have multiple fold of a normal diploid chromosome set. So that's normal, that these nuclei are sticking together. That's normal. So if that is normal, obviously here on the left side, the left upper corner, that's abnormal. We are calling this nuclear separation. Sometimes you have a megakaryocyte with only one of these small nuclei. So they are micro-megakaryocytes. That sounds like an oxymoron. Why can something that's large be at the same time small? So micro-megakaryocytes. And here you see also prominent megakaryocytic hyperplasia. Here on the bottom, there are some cells that are really hypogranular. They belong to the myeloid lineage. Here again on the left side, hypogranular myeloid cells with pseudo-pergahuid morphology. And again here, a highly abnormal and dysplastic megakaryocytes that contains multiple dissociated nuclei. That is absolutely abnormal. The nuclei in a normal megakaryocyte represent a nuclear convolute where all the nuclei are sticking together. So this is myelodysplasia. Myelodysplasia in the red cell lineage. So look at the bottom, you see highly abnormal nucleated red blood cells here. We call them snowman forms. So this is dyserythropoiesis. So that's also something you see frequently in a myelodysplastic syndrome. And so another feature of dysplastic erythropoiesis is the presence of ring sideroblast. Ring sideroblast contain iron in mitochondria, and they are surrounding the nucleus. So ring sideroblast is not specific for myelodysplasia, can also be seen in alcoholics, but in most commonly it's seen in myelodysplastic syndromes. And what is really nice, we have a lot of chromosomal changes in myelodysplasia, and I'm not going to show you here everything that's possible. Many cytogenetic changes can be present simultaneously, and then we call it a complex karyotype. Here I show you a typical karyotype for somebody with myelodysplasia. It could be even a loss of chromosome 5, or a loss of chromosome 5q, or a loss of chromosome 7 or 7q. And so you can easily detect this in conventional cytogenetics. On the right side, you see the corresponding fish pattern for chromosome 5. On the left upper corner, that's normal. You have two signals for the two chromosomes 5. And on the right lower side, the 5q is missing, or the entire chromosome 5 is missing. There's only one red signal. So we're using fish studies in conventional oncocytogenetics in all of our bone marrow biopsies. And we have help. Let me just explain this a little bit confusing slide. We have a fantastic artificial intelligence-driven automated chromosome analyzing and FISH instrument from Metasystem, which is a German company. So you see, we have the conventional karyotype here on the left, and we have FISH studies on the right. And guess what? Based upon AI algorithms, the instrument completely automatically does the characterization in a very, very short time. This allowed us to increase, the volume of our testing enormously. The accuracy of this instrumentation is above 99%. So our oncocytogeneticist, Dr. Banowski, looks at these data and signs off on them. It is fantastic. It helped us to multiply the productivity of this laboratory. All right. Here's another very important criteria, and it doesn't need a rocket scientist to make this assessment in many cases. As I mentioned to you, we have three major lineages in the bone marrow: the myeloid lineage, the erythropoietic lineage, and the megakaryocytic lineage. That's, of course, a simplification. Within every one of these lineages, maturation takes place, and that makes up this so heterogeneous appearance of normal bone marrow. Whenever you see something on the left, homogeneity, where everything looks alike, this cannot be normal. So when something looks alike here, like these cells here on the left, which represent a blast population, that is probably leukemia. So we, of course, have, if you divide it into major groups, we have acute myeloid leukemias and acute lymphoblastic leukemias. We are talking about acute leukemia if we have more than 20% blasts. And here on the right side, you see these immature appearing cells. So you see these hand mirror forms. That is a characteristic feature of acute lymphoblastic leukemia. So homogeneity versus heterogeneity. We do not like homogeneity. That means one cell type has taken over here and displaced the normal maturing hematopoietic elements. So and here is how this looks by flow cytometry. On the right side, I show you again a normal diagram for flow cytometry. Here on the left, in the blast region, you have a population that makes up 70 or 80% here. So we can identify this cell population separately. So to have 70% blast is not normal. That is normally characteristic of having an acute leukemia. And as you can see here, you can now gate on this cell population and identify its immunophenotype. In this case, it's positive for B cell markers. It's also positive for TDT, terminal deoxytidyl transferase, which is a marker that is more commonly expressed in the lymphoid lineage, and it's not seen in mature lymphocytes. So you can draw two conclusions here: that this population that's TDT positive is an immature lymphoblastic cell population consistent with acute lymphoblastic leukemia. It's also positive here, as you can see here, for B cell marker CD19 and CD10. There's another name for CD10, which is CALA, common ALL antigen. So this is a typical immunophenotype for acute lymphoblastic leukemia of B cell type. So we always look, of course, for the karyotype of an acute lymphoblastic leukemia. And in this case, you can see a reciprocal translocation between chromosome 9 and 22, resulting in an abnormal chromosome 22, which is called the Philadelphia chromosome. How appropriate that I gave you this presentation tonight from Philadelphia. So this is Philadelphia chromosome, and you can prove this also by fish studies. You have a normal and chromosome 9 and 22, and then you have the derivatives, which result here in this yellowish color. So that's another way to prove that this is Philadelphia chromosome. Here we have another example for a precursor B-cell leukemia, an acute lymphoblastic leukemia of B-cell type, which very characteristically very often have a hyperdiploid immunophenotype. You see a number of trisomies here. So it's also fairly typical for a precursor B-cell leukemia. Now, we discussed an example of an acute lymphoblastic leukemia. Now let's discuss an example of a myeloleukemia. It's actually an important diagnosis to make. And it says here, a diagnosis you cannot miss. So you see all these promyelocyte looking cells here. You have some OR rods. So why don't you want to miss this diagnosis? Because these patients come normally in DIC, disseminated intravascular coagulation, because there are chemicals released from these granules which induce coagulation. If you give these patients normal, quote unquote, normal chemotherapy, you release even more of these chemical substances from these granules, and you push the patient even more deeply into DIC, and you can kill him. Now what needs to be done is, in these patients, you have to give alpha-retinoic acid, which makes the cells mature and actually mitigates against DIC. And so what you have to do is you have to demonstrate, again, a reciprocal translocation between chromosome 15 and 17, which is the PML-RARA genes. And again, you have normal here, and then you have the fused genes. So very important, life-saving. When we have a patient who comes in and the clinicians look at peripheral blood smear, and they say it could be acute promyelocytic leukemia, we do immediately the FISH study. And Dr. Banowski turns this around, I would say 5-6 hours. And we have the results. We rule in and rule out acute promyelocytic leukemia. So very important. It's really, that is one of the emergency situations for which our people have to come in on Sundays. So these were two examples of acute leukemia, and the unifying prerequisites for acute lymphoblastic and acute myeloleukemia is they have to be at least 20% blast. Now I'll show you an example for a hypercellular bone marrow, and we saw this case before, in a patient with chronic myeloleukemia, 50 years old. Obviously, this is hypercellular. This is an example, again, for effective hematopoiesis, because this patient had a white cell count of 150,000. And a hallmark of chronic myeloid neoplasms is the increase in reticulum fibers. In a patient with CML, you see the significant atypical megakaryocytic hyperplasia. All these little guys here are megakaryocytes, and in this case, we speak of small and hypolobated megakaryocytes. On the right side is a stain for CD61, which highlights the megakaryocytes. So, as you know, in CML and in myeloproliferative neoplasms, you have very often basophilia, as you can see here. Here's also an eosinophil. So you have an increased number of basophils and eosinophils. So in this case, again, you can demonstrate Philadelphia chromosome. It's a 922 translocation, and which can also be demonstrated by FISH. And you have the fused gene here between BCR-able, so the 922 translocation and the chromosome 22 again being the abnormal Philadelphia chromosome. So that's one way to do this, but you can do it also differently. So we are doing our NGS for leukemias in-house. So what you see here is that this patient has two major breakpoints for a BCR-able translocation. So this is done by next-generation sequencing, which again confirms the diagnosis that was already clear from our FISH studies and conventional cytogenetic studies. Now, if you have a patient with chronic phase myeloid leukemia, chronic myeloid leukemia, let's say you have a peripheral blood, and you do flow, it's indistinguishable from normal. The leukemic maturing abnormal myeloid cells have the same immunophenotype as normal myeloid lineage cells. However, in this case, the patient had a history of chronic phase myeloid leukemia, CML. You see there's an increased number of blasts, which I think was in the range of 30%. So that is consistent with a diagnosis of blast phase in chronic myeloid leukemia. And here are some other examples of the myeloproliferative neoplasms. So for which you see certain mutations. I mean, for example, for polycythemia vera, JAK2 or JAK2 exon 12 mutations, primary myelofibrosis, essential thrombocythemia, etc. I would be very uncomfortable to make a diagnosis of ET, for example, if I did not have at least one of these mutations, MIPL here, or calreticulin, JAK2, etc. So this is why we do next generation sequencing in all of our hematologic malignancies. And again, the hallmark is fibrosis, and it's graded grade 1, 2, 3, and this is grade 4. So reticulum fibrosis is a characteristic feature of myeloproliferative neoplasms. Okay, another scenario. On the left and on the right side, we have hypocellular bone marrow. And in both of these cases, the peripheral blood findings represented pancytopenia, ineffective hematopoiesis. So this could be an aplastic anemia, which is on the left, or it could be a hypocellular MDS. In aplastic anemia, you don't see any dysplastic features that you would see in hypocellular MDS. But it's an example for ineffective hematopoiesis in a hypocellular bone marrow. So you see hardly many white cells in the peripheral blood. You see a hypocellular bone marrow. So that is an example for aplastic anemia. Now, another example for a leukemic infiltrate, in this case, it's not chronic myeloid leukemia. It's an example for chronic lymphocytic leukemia. So relatively easy to recognize, I mean, diffuse infiltrates of small lymphocytes. What the clinicians always want to know from us, whether there's any evidence for transformation, for example, into Richter syndrome. So in this case, it was just small lymphocytes. As a general feature for lymphomas or lymphocytic leukemias, of course, there's an increase in lymphocytes. And you see here, this is the lymphocyte population, which probably was in the range of 90%. For all lymphomas and mature lymphocytic leukemias, you want to be able to show light chain restriction. You can do this by flow cytometry. Here you have 94% of the cells that express light chains express surface lambda. and only 5% express surface kappa. So that is enough evidence to assume that this is a clonal lambda light chain B cell population. In addition, of course, you can use all the other markers that Dr. Behling described. For CLL, it's CD5, aberrant expression of CD5 or CD23. But for all mature B cell malignancies, you want to be able to identify clonality. Not always do you have a flow cytometry specimen, so you can also do this by demonstrating clonal IGH or kappa light chain gene arrangement. The graph on top, of course, is polyclonal. You have all these different spikes, and the graph on the lower right side represents a clonal spike. So that is really, I mean, we are using tests for to determine IgA gene arrangement all the time, because sometimes you don't know, is this a clonal B cell population or is this polyclonal? In addition, then, of course, we have all the markers, the other markers, to identify an abnormal B cell population. So here's an example for plasma cell myeloma. I don't know how it is in your practices. We see an enormous amount of plasma cell neoplasms, plasma cell myeloma. So including abnormal plasma cells here like MOD cells, or we see plasma cells which have cytoplasmic inclusions, which are Russell bodies. So these, of course, need to be worked up, and clonality needs to be proven. A nice marker by immunohistochemistry for plasma cells is CD138. You can also use MUM1, and here we have done an in situ hybridization for kappa and lambda light chains. So it's pretty clear that this is clonal. In particular, in lambda light chain positive plasma cell myelomas, you may see amyloid deposits, which you can see here on the left in a Congo red stain, and on the right side in polarizing light. And of course, very helpful is serum protein electrophoresis with immunofixation. So in this case, you see the two bands identified here, I think, as IgG kappa. Unfortunately, I cannot read this here because the text is covering my slide. So in any event, of course, we perform flow cytometry on these specimens. So here in the middle, you have a CD38, CD138 double expressing plasma cell population. Before you can assess the light chain expression in a plasma cell, you have to permeabilize the cells. And on the right side, you see that this plasma cell myeloma is cytoplasmic kappa light chain restricted. Multiple cytogenetic abnormalities can be seen in plasma cell myeloma, even the BCL1 translocation, the T1114. So I'm approaching the end of my presentation. We do, as I mentioned before, for all of our bone marrow malignancies, next generation sequencing. And I mentioned already to you why. Because number one, for diagnostic reasons, here you see, for example, an NPM1 mutation. So if an acute myeloid leukemia has an NPM1 mutation, it is defined by this mutation. That is an entity. You don't make the diagnosis based upon morphology alone anymore. There is an entity that is called AML with NPM1 mutation. The second reason, of course, is we try to identify potential therapeutic targets. This is why we do next generation sequencing. And in our laboratory, we are currently in the process to essentially expand our NGS panel to all malignancies, also in the solid tumor arena. So here it is. This is, you don't have to read all of this, but here you see the AMLs, which are cytogenetically or molecularly defined. Here, for example, AML with NPM1 mutation. So you have to do this, otherwise you cannot diagnose certain types of AML anymore. Here's another nice example where a mutation, here the SF3B1 mutation, predicts a certain morphology. If you have a missense or other mutation in this particular gene, you can predict that the patient will have ring sideroblasts. So this is my summary. This is my last slide. And I know how tired you guys must be. So what is important is when you determine cellularity, and when you determine cellularity is normal or abnormal, you need to know two variables. You need to know from where this biopsy was taken. And secondly, you have to know the age of the patient in order to determine whether it's normal or abnormal. We talked about homogeneous versus heterogeneous appearance. Homogeneous is bad. If all the cells look the same, it means they have displaced the normal heterogeneous elements of a normal bone marrow. You have to know the CBC data. You have to be able to determine whether something is ineffective or effective hematopoiesis. If somebody has a hypercellular bone marrow and has 150,000 white cells, this is effective hematopoiesis, most consistent with leukemia. If somebody has 100% cellular bone marrow, but only 2,000 white cells in pancytopenia, that in all likelihood is some kind of ineffective hematopoiesis, most likely a myelodysplastic syndrome. In lymphomas, we want to be able to identify clonality. For T-cell lymphomas, we like to see a positive T-cell receptor gamma gene arrangement pattern. For B cells, we like to see a positive IgH gene rearrangement pattern or a kappa light chain gene rearrangement pattern, etc., etc. So clonality is an important criteria for the diagnosis of malignant lymphomas. So I cannot read this. It's covered, my orange slide. I don't know what it says. Ultimately, the last point I was making was next generation sequencing, which you have to do these days because, as I've shown to you, many hematopoietic malignancies are defined by certain mutations. Now I know again what the orange field meant. These are ancillary technologies, such as flow cytometry, immunohistochemistry, oncocytogenetics. So they are also very important to make a final diagnosis of any type of hematologic malignancy. So it is late, and I would like to thank you for your patience. I am done.
Thank you so much for this wonderful lecture.
Let me stop sharing here. Okay, I'm back here.
Do you have any question, Isabel?
Isabel?
Yeah, just one question. Are there some cases that you just need the flow cytometry in order to do the diagnosis, or there are cases in where immunohistochemistry is better than the flow cytometry in order to do a diagnosis?
Yeah, that's a very good question. So the first answer is we do not always need all these technologies for every single case. If somebody has something as easy, I call it, like a CLL, flow cytometry may be perfectly all right. In cases, for example, where mantle cell lymphoma is suspected, we don't run BCL1 or SOX11 by flow cytometry. So the reason why we may suspect mantle cell lymphoma is that it is a CD5 positive B cell lymphoma. In those cases, we need immunohistochemistry, at least BCL1 and SOX11 to confirm this diagnosis. So the value of these ancillary technologies varies. So our clinicians sometimes are not even happy enough. They're very demanding clients. If we determine BCL1 or SOX11, they want then the chromosomal findings. So they want the proof for the T11 14 translocation. So the value varies significantly.
Okay, thank you so much.
All right.
I have the last question.
Aha.
What will be the impact of the artificial intelligence in the future of the hematopathology?
Numerous impacts. Actually, I'm currently preparing a presentation for September in China again. They invited me. I'm talking about artificial intelligence in pathology. So there are some interesting applications for hematopathology. There's an American company that does fully automatic evaluations of peripheral blood smears and bone marrow aspirate smears and gives you an accurate and correct quantitative analysis. You get a differential within seconds. So, to put this into a more general perspective, yes, there will be a lot of applications which will interpret digitized images. But I see one area which is almost more important. I don't know how you do it. When I sign out a bone marrow, for example, then I have to wait for the molecular findings, the next generation sequencing finding, the immunohistochemistry, the flow. Artificial intelligence could combine all this data and create a synoptic report. It would save me a lot of time. There's another instrument, for example, as you know, AI sometimes results in some kind of robotic device. This has nothing to do now with hematopathology, but we had a meeting with a company 2 weeks ago, and they offer the first instrument that does fully automated section cutting. It's called the robotome. No more histotext necessary that have to cut tissue sections. It's all done by a machine. The machine cuts as many slides as the equivalent of 5 histotechnologists. The nation that is by far the most ahead in artificial intelligence in pathology is the Chinese. They started in May, AI hospitals. You go into this hospital, you're not greeted by the human being anymore. There's a robot coming towards you who knows you, who recognizes your face. He knows your entire medical history. It is so beyond imagination. It's amazing.
Wow. 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 Well, we are coming to the end of this beautiful session. We really do apologize for all the problems, but it happens. It's part of the sometimes of the technology. So I will invite you, Isabel, to say the final word of this session. Please go ahead.
Well, again, for us, Dr. Belling, Dr. Schwarten, I don't know if the right pronunciation, but thank you so much, because it is not easy to have such a bird of experts giving us this very usual lectures in making us a more easy way to face these diseases. And thank you so much. And we hope that having you in the future in person in some of our meetings. And thank you so much. Y para todos las personas que estuvieron presentes hoy en este curso, pues bueno, creo que también están muy satisfechas porque, pues a pesar de los problemas técnicos que siempre pasan, fueron unas ponencias espectaculares. Entonces, muchas gracias y buenas noches. Thank you very much and good night.
So the final words, Roland and Eric, we had 65 students attending to the lectures. And something that is very important is to let you know that these lectures reach uh, to the remote parts of Latin America, where many pathologies they have only the basic things, right? So this is very important, and we really do appreciate all your effort, your time, and your patience to teach all of us. So I hopefully meet you with Isabel, that is my partner. We were working for many years together, but
Yeah.
we really want to meet you in our next meeting. It will be a great honor, and thank you very much for your heart and your love.
Thank you very much. You have been great moderators. Thank you for the invitation, and greetings to all our friends in Latin America.
Thank you.
Have a great
Thank you.
night.
Yes.
Bye.
Okay. See you soon. Thank you very much.
Yes.
Thank you very much again. Good
Okay.
night.